You're listening to the ATS Breathe Easy podcast, brought to you by the American Thoracic Society.
Hello and welcome. You're listening to the ATS Breathe Easy podcast with me, your host, Dr. Eddie Qian. I'm also the host of the ICU Ed and Toddcast. Each Tuesday, the ATS will welcome guests who will share the latest news in pulmonary and critical care and sleep medicine. Whether you're a patient advocate, or healthcare professional, the ATS Breathe Easy podcast is for you. Today, we're going to be talking about the current state of procedural training and training programs. And joining me today are two really special guests, Dr. Meredith Pugh, the Program Director of the Pulmonary and Critical Care Fellowship Program at Vanderbilt, and Dr. Kaele Leonard, who serves as the Associate Program Director for Procedural Education for the Vanderbilt Internal Medicine Residency Program. Welcome, Meredith and Kaele.
Thanks for having me, Eddie. It's a pleasure to be here.
Yes, thanks.
Let's just jump, I think, right into it. And so we're talking about procedural training. Why are we talking about procedural training? Why is talking about procedural training important? Why does an internist or a pulmonologist or an intensivist need to know procedures?
I think procedure training is important for a number of reasons. Now, granted, I think about it more day to day in the care of patients in the ICU and on the pulmonary floors, and then also think about it as the perspective of a training program director. And procedures are part of what we do in all of those different arenas. And then thinking thoughtfully about how we prepare our trainees to serve their patients in different arenas and be capable and competent proceduralists is an important part of my job. When we're talking about procedures, we're talking about not only the things that we most commonly think of when we talk about procedures, like putting a needle into a space for a diagnostic or therapeutic purpose, but I think in today's medical practice era, we're also talking about things like point of care ultrasound that may not be a procedure in the classical sense, or even things like ACLS training. But they're opportunities for us to care for patients that require practice and training and require specific attention in the context of training. I think the other thing is anyone who's been involved in medical care, or certainly in medical training, probably has a visceral sense that there has been some evolution in the way that our regulatory agencies like the ACGME and ABIM are thinking about procedural training. There's some changes, and there's also a visceral sense of trainees coming into fellowship, for example, with slightly different procedural training and backgrounds than what was the case, 10 or 20 years ago.
You mentioned, Meredith, talking about there's a sense that procedural training has changed over time. What can you describe to me this change? Where are we today?
I think I can start us off with this one. When we think about program requirements for different training programs, the ACGME has different program requirements depending on the program and wants trainees to be able to perform all medical, diagnostic, and surgical procedures for that area of practice. But then specifically, the ABIM has changed what they require from a procedure standpoint for the internal medicine resident over time, where they state all residents must do procedures, but not all residents must do all procedures. And that residents also should have the opportunity to develop competence in those procedures that will further their development in their career choice or subspecialty fellowship that they're pursuing. So historically, there were certain bedside procedures where there were number requirements that you had to hit, and now that has gone away. What is required by the ABIM is to obtain informed consent, apply standard sterile precautions in a sterile field, and be able to apply local anesthetic. However, the new guidelines allow individual internal medicine program directors to tailor the procedural training for their residents, for their specific residency, and also for specific residents.
So I think those changes within the internal medicine residency training structure have definitely impacted what we're seeing when trainees enter into our fellowship program, and really a variety of different approaches to this across internal medicine training programs in the country. But in general, there has been a shift away from a discrete number of procedures that would indicate competency to a more holistic evaluation of competency that is different than just a blanket number of procedures. And then also different experiences across trainees in terms of bedside procedures. Like if you're as old as I am, it used to be that every patient in the ICU that was on norepinephrine got a central line, placed by residents in the program. And so entering into fellowship in my era, we had accumulated a vast experience in the placement of central lines. In the current era, not only because of those changing guidelines that Kaele mentioned, but also because of increasing use of peripheral vasopressors, the ubiquitous nature of PIC teams and other procedural teams at the hospital, all of those things together have really changed the experience of internal medicine residents. So they may not have as much exposure to central venous catheterization, by the time they enter into fellowship. And so that just means we've had to think about ways to adjust our experiences of making sure that fellows get those experiences in our program.
We've talked a little bit here about being competent with procedures and for different types of procedures and tailoring them and getting away from some of these quotas, so to speak, of the baseline number of procedures. Is this the right thing for us for our training? Should our medicine trainees be quote unquote competent with bedside procedures?
I think that it really just depends. I think that there are certain procedures that internists should be able to do, or at least have the opportunity to do. But with the changing landscape of medicine and procedures, like Meredith mentioned, I don't think should be a requirement that all residents are competent in all of those different procedures. And I think it's a good thing that residencies can tailor their training and their requirements to their particular residency. So for our program, for example, we have decided to require residents to be competent or signed off for indirect supervision on paracentesis and Dabov tubes. And the reason we made that decision was due to the high volume of those procedures and often time-sensitive nature of them, that we thought it was important that all residents be able to do that. And then we also require ACLS certification to be current for all of our residents. For other bedside procedures, such as central line, thoracentesis, lumbar puncture, we encourage but do not require residents to be competent or signed off on those procedures. However, we do encourage or try to tailor someone's procedural experience to what their future career goals are.
When people enter into our fellowship program, the ABIM is pretty clear about what procedural competency, or I should say what procedures are a requisite part of training within the field of pulmonary and critical care. And so unlike internal medicine that has really moved away from specific procedures, we have no numeric requisite, but we do have procedures. And as a program director, I do need to have a way of verifying that my trainees are getting adequate numbers of these procedures with supervision that are achieving a certain level of competency. And that includes procedures like fiber optic bronchoscopy, airway management, arterial puncture, central venous catheterization, and even the use of bedside ultrasound or point of care ultrasound, especially for central venous catheterization. So I think when you look at other subspecialties of internal medicine, like oncology or rheumatology, program directors in those areas probably have a very different perspective on what procedures they want their fellows coming into their program with. I'm very grateful that others have done work in this area. So Effie Singas and colleagues published a survey that they sent to internal medicine subspecialty program directors. And there's quite a diversity of perspectives about which procedures IM subspecialty program directors want their incoming fellows to be have experience and competency in. For example, in the field of pulmonary and critical care medicine, which is obviously a procedure heavy field, 3/4 of program directors surveyed wanted their incoming trainees to have had experience in abdominal paracentesis, which sounds like they'd be fine coming from Kaele's program into fellowship. And almost 90% wanted their trainees to have had exposure in venipuncture, for example. Whereas when you look at oncology, 100% of surveyed program directors wanted their trainees to have had experience in lumbar puncture, which makes a lot of sense, but not as much of a desire to have training in central venous catheterization. So I think just from the program director standpoint, I'm balancing the need to have our trainees exposed to very specific procedures that are part of our daily life and part of ABIM certification, but then also ensuring that it's the right type of exposure where trainees can develop competence.
Yeah, it seems like it's a really difficult job for the residency programs to kind of cater to every individual subspecialty. There are a couple of points I want to come back to, but we spent a lot of time talking about competence. We've talked about a holistic approach to competence. We've talked about maybe quotas aren't the right way to do it. For both bedside procedures and even more advanced specialty-specific procedures like bronchoscopy, what does it mean to be competent in a procedure? And in an ideal world, what kind of level should someone achieve before they're declared competent, quote unquote, for independent practice?
So I think that that landscape has also changed over time. I think we've moved away from the see one, do one, teach one, and with the decreasing number of procedures overall, I think in an ideal world, starting with a simulation way to learn is probably a great way to sort of initially learn these procedures. I think that it allows for a safe, hands-on way to kind of work through the steps before you're doing it in the real world or on a real patient. So there's actually a group out of VCU that has implemented a competency-based procedure curriculum where they used a checklist-based simulation training where all the residents had to be checked off on the steps of the procedure in a simulation environment before they moved to the real world. And then they also had a procedure committee, competency committee that looked at the feedback that people had on their procedures and numbers before they determined that somebody was competent. So that sort of starts from that simulation setting, moves to a real world supervised setting before that trainee is deemed competent for indirect supervision to perform the procedure without having somebody watching them the whole time. So I think that is sort of an ideal world situation. And just commenting briefly on to add to something I mentioned before about what should internal medicine residents do. I also think it's specifically important that they at least understand and know the basics of all these bedside procedures that their patients are having. And so implementing a curriculum where they get some didactic or simulation training on all these different bedside procedures that are within the scope of internal medicine, I think is helpful just for their understanding their patient care and, potentially affecting their future career as well.
Yeah, it makes a lot of sense to kind of demystify these procedures for trainees not even just bedside procedures, but even to some extent, the relevant surgical procedures that otherwise are important for us to know when we're talking with our patients.
Yeah, and I think that's important too, because when you think about, even if a trainee is not going to be performing the procedure themselves, they may be able to explain it to their patient and their family member better when they understand a little bit about the procedure. Also, I think an important skill and part of procedural training is not just the steps of doing the procedure itself, but also being able to recognize a patient who may be at higher risk from a procedure, or being able to navigate and lower the risk of certain aspects of the procedure. For example, a highly anxious patient, if you know what it's like to have to put someone in a position to place a central venous catheter, and they have severe orthopnea and they're very anxious, that you should recognize that ahead of time, that procedure may place that patient at higher risk and potentially have additional hands at the bedside or a change in procedural positioning. And if you don't fully understand what it looks like to put a central line in, then you may not have that knowledge ahead of time. And so I think even as we're talking about procedural training, we don't want to lose sight of aspects of the procedure management, informed consent process that are outside the actual hands-on performing the procedure itself, that are equally important aspects of training.
Yeah, that makes a lot of sense. So what we're talking about is that you don't have to actually do the procedures to have the knowledge of what the procedure is and how things, kind of real logistics of doing the procedure can really impact the way that you take care of patients before and after. Because in theory and ideally, we're taking care of these patients before and after procedure, if not during.
Yeah, that's right.
Yeah. So Kaele, should we all be moving towards this VCU model that you had talked about, where we start with the sim and then check off and then move to a real world kind of scenario and get checked off again? It really seems like a pretty large lift. And you said that this field is evolving.
Yes, I definitely agree with that. It does seem like a very large lift. I think that is an ideal scenario when you have a very supportive program. You have the time and faculty support for that. Ultimately, they've published again and saw that their curriculum and committee resulted in an increase in the volume of procedures that the residents performed and that they supervised, which is great. But
Awesome.
if you don't have that kind of support, it's hard to implement something like that. And so I think there are ways to optimize or improve a procedure curriculum in smaller steps. So I think it's important, as I mentioned, that all residents get a basic understanding of these bedside procedures. And so we are implementing a longitudinal curriculum that's part didactic and part simulation hands-on training throughout their intern year. Now, they haven't had their paracentesis simulation yet, but they might have already had the opportunity to do a bedside paracentesis. And so I think if that is the case, their supervising provider should recognize that, and they're going to do some more coaching, reviewing of the procedure steps, maybe a video prior to that experience. And so the way it's playing out is it's not always going to be a perfect, they do simulation before they do the bedside procedure, but at least it gives them some baseline of the baseline training in that procedure as they progress through their residency. And so I think that, having some amount of training and having a way to assess competency, I think is important for whatever works for your training program.
Yeah, I think on the fellowship side, recognizing that we do not operate at all in anything close to a perfect world, we realized very early on that we did not have the organization and the time to do a full curriculum as was described in the VCU papers. But it's most critical for us to have an adequate training, adequate supervision, and then a standardized approach to establishing competency for procedures in our fellowship. And so what this has looked like for us is, first, I start collecting data about our incoming fellows' procedural experience from their residency programs before they even hit the ground in our program. And I collect not only the number of procedures and ask for information about procedure logs, but I also query whether or not their training program had a competency-based way of assessing procedures. Then during our orientation for our fellows, I meet with each trainee one-on-one and hear a little bit more about their procedural training so that we can personalize the high yield aspects of their procedure and hands-on training during those first few weeks of fellowship. Then we developed a robust Jumpstart curriculum that includes some high fidelity simulation, some a model and some cadaver-based training for the procedures that our fellows do most commonly, including bronchoscopy, thoracentesis, chest tubes, and central venous catheters. And then we utilize a program that allows me to see how our faculty are rating proceduralists. And that gives me information not only about the number of procedures they're doing, but whether a faculty supervisor has rated them as novice, intermediate, or expert or practice ready. And so for our program, for example, we do require a certain number of procedures and a certain number of expert or practice ready evaluations in order to allow a trainee to proceed with performing a procedure with indirect supervision, meaning not having a faculty member directly at the bedside with them.
Yeah, that makes a lot of sense. We know that, learning curves for all things, not just procedures, are different for different individuals. So it makes a lot of sense. But I just like to highlight that I think one of the things that is really coming out of this conversation is that though we may not live in an ideal world, that it's important to think about it and kind of be moving in that direction. And that maybe that's a lofty goal we'll never achieve, but I think it's really, really important to just have active thoughts and to be moving in that direction. So we thank you for both of you for all you're doing there.
When you become a member of our global American Thoracic Society community of more than 30,000 healthcare providers and researchers, you'll have access to cutting-edge science through ATS journals and publications, discounts on the annual ATS International Conference, CME, and ATS Ed Plus products, and a robust, collaborative online medical community of peers in our ATS Doc Matter community. Join today at thoracic.org/join.
I want to come back to a point that Meredith, you mentioned at the very beginning, and it's Meredith, Kaele, either of you can comment on this, but talk about not just sticking a needle into spaces, but also ultrasounds, point of care imaging. It's really become ubiquitous in the ICUs. It's pretty ubiquitous on the wards as well, in the clinics even. How much of the conversation that we've just talked about changes when we're talking about ultrasound used as a diagnostic tool, or you could call it, quote, an imaging procedure, so to speak?
Yeah, so I'll start off by mentioning that the ABIM does recognize ultrasound as an important skill, specifically for pulmonary and critical care. It's mentioned that fellows must achieve competency in use of ultrasound for placement of central venous catheters. However, other statements talk about the importance of procedural and technical skills of bedside ultrasound, including image interpretation and image acquisition, which are skills outside of just utilizing it to successfully place a central venous catheter. And I think there are several implications of these recommendations and the need to observe our trainees performing point of care ultrasound. One is you have to, as a program, have enough ultrasound machines to make sure that trainees have access. Two, you need to have adequate numbers of faculty who are competent in the use of ultrasounds and have availability of faculty and ways within your program where faculty will be present to observe fellows or trainees performing ultrasounds and be able to provide feedback on that. Three, it is exceptionally helpful to have an image archiving system so that images could be reviewed, perhaps not in real time, but at a separate point in time, and that trainees can then have an archive of what they've done to demonstrate that they're able to proficiently obtain images. And so even those three requirements are a lofty goal for some programs, depending on where you're practicing. We're fortunate here to have availability of faculty within our own pulmonary and critical care program, but also we rely on expertise from other divisions, like our emergency medicine has a wonderful ultrasound fellowship and are heavy utilizers of ultrasound. And so we realized that we did not need to reinvent the wheel and that we had experts in our own community that could help and partner with us in the training of our fellows. And so that's been a wonderful a way to kind of help cross-train at our own institution. The other thing specific to ultrasound is that, and really is true for a lot of these things that we've been talking about, is that we're not going at this alone. Like as an individual program director, as an APD in the residency program like Kaele, we can rely on the expertise, the wisdom, the experience of our national community And already there are a lot of discussions and surveys and input from the Association of Pulmonary and Critical Care Medicine Program Directors, for example, which is oftentimes a litmus test for me to understand if my own experiences that I'm feeling are similar to what's happening in the national community, and from learning from each other. And then in terms of training, there's also already great established curricula that are available, some online and some in person through national organizations. And so I think that program directors and faculty should take heart that if you're hearing this and you're thinking, well, I don't have all of these things available to me at my institution, there's some really great resources available nationally that can help fill this gap in helping you train your residents and fellows.
I would also just like to add that ultrasound is becoming more common within just the general internal medicine space as well. And the experience that residents get is variable across different programs. And some actually are coming in from medical school with ultrasound experience. And so having a way to support at least some ultrasound education alongside your procedure training, I think is really helpful, especially since the majority of these bedside procedures we're doing with the ultrasound guidance. And so finding a way to at least incorporate that along with your bedside procedure training, I think is really helpful. And I agree with Meredith. It's not just the pulmonary and critical care national organizations. There's also general internal medicine organizations that have excellent courses if people would like to get further certified in those things.
Yeah, that part when you're talking about like medical students coming in with ultrasound experience has really I've really noticed that. I do some teaching with the medical students, and where they are far beyond where I was talking about ultrasound skills and knowledge as a medical student. That's all this knowledge I learned during residency or during my fellowship training. So it really is a kind of like a shifting landscape, and it will depend on people like you and Meredith to adapt as the landscape continues to shift underneath us. But I wanted to come back a little bit to like talking about general internal medicine, bring it back to the procedures, the classic procedures. And I wanted to talk about this kind of phenomenon that's been going on, talking about procedure teams. So they're more and more common. These are teams of clinicians who have an interest in procedures, and they can be run by general internal medicine, or in some places it's run by pulmonary critical care. How does this impact, I think, both patient care and then separately the trainee experience?
No, that is a great point. And we've seen this at our institution, how this has sort of changed the procedure landscape. I think in general, having a procedure team of people who have an expertise in procedures is going to improve, patient care and patient experience. I think that the way we have it structured, residents can opt to rotate through this procedure service after their intern year. And that is a great way for them to get dedicated, high volume procedures where you have a built-in supervisor, you're getting high quality teaching, and you get a lot of reps at one time. And so the residents who are interested in procedures can self-select into, I want to get more experience with these procedures. And so I want to do this, and that can help them become competent in these bedside procedures. I think the other effect of that is it allows or it reduces the number of bedside procedures that residents are doing, because it allows them to say, from time constraint perspective, I don't have time to do all these procedures. I need help. And then, if their senior resident on the team is not signed off on procedures, they aren't able to supervise the intern who might be interested, and that often gets passed on to the procedure team. Now, kind of a way to combat this is the way our procedure team works is when requested, that procedure service attending can be the supervising provider for that intern. But again, I think it requires some initiative and the time to do those things. So I think that there are certain pros and cons to this procedure service, but it really has allowed the residents interested in procedures to get some of this extra hands-on time.
And I think there's some advantages too from a supervision standpoint. I mentioned that when we're thinking about competency and establishing what competency looks like, it's not just the number of procedures, but it's having a standardized approach. At our institution, it's a checklist for a procedure. And so it's having a group of faculty who are very facile and familiar with that checklist, who understand the steps that it takes to perform a thoracentesis start to finish like an expert, and then to have the trainee observe the trainee be able to execute that, and then to provide very specific feedback about why a trainee wasn't at expert level. And so I think with a procedure service, you have kind of distilled down a select group of faculty who may be very familiar with that process and even understand the technology that we use and the program that we use that houses this information. And that's another benefit for training and education. We've even considered in the pulmonary and critical care realm, not so much in the ICU, but with a high volume of pulmonary consults and a large volume of bronchoscopies and pleural procedures that's done at our institution. We've thought too about a specific pleural procedure service. And I know that there are peer training programs in the country who already are doing this in a way to have their fellows achieve very focused procedural training, with lots of repetitions over the span of several weeks to really focus in on that training.
Yeah, and it is interesting because if you're saying, oh, these providers are interested or specialized, and they themselves, the supervisors, have a lot more experience, that you could say that I'm not sure there's data for this, that potentially the patient care experience is enhanced as well. But I think there's a couple of ways that we can aid our trainees. One is through having boots on the ground experts and a lot of people with a lot of skill who are willing to teach. But another one is I think, Meredith, you mentioned familiarity with technology. And I think listeners of the podcast might think I'm getting kickbacks from big AI. I promise that's not the case, but it really is a real world that there's a rapid turnover of technology. There's now AI and technology-driven procedural aids. There's ultrasounds with needle finders. There's new different types of bronchoscopy with cone beam and robotic bronchoscopy. Is there value in teaching the old ways here? And if you do think there's value in that, how can you find the time in the same training program, 3 years internal medicine, 3 years pulmonary critical care, to teach the old ways and then also prepare people for the new things that are coming up?
I think that's a great question, Eddie. And I'm not sure that I have all of the answers to what sort of the future of AI holds. But I think that to answer that, I would have to think about procedures specifically rather than in general, because I think this varies by the procedure and your particular practice environment. So in my training, I've used ultrasound or other technology in the vast majority of my procedures that I've done, but I practice in a high resource setting, and I always have access to ultrasound in the ICU for an emergent procedure, whereas that might not be the same for somebody who practices elsewhere. However, technology is not foolproof. And some technology, especially the newer AI technologies, are not well studied. So there is still a benefit, I think, to understanding how to do procedures blind or without this technology. So an example of this may be video laryngoscopy, which is shown to increase first pass success for intubations. But I personally believe it's important to learn how to do direct laryngoscopy for intubation, because the light in the camera might not work and you're having an emergent intubation, or there's a lot of hematemesis or hemoptysis that is obscuring your view. And so I think it's still important to have some training in how to maybe do direct laryngoscopy. I think for other things, say bronchoscopy, for example, that may be less emergent, relying on something like EBUS, endobronchial ultrasound, is going to significantly improve your diagnostic yield. And so that is something that I don't know, or I personally did not learn how to do biopsying of lymph nodes in the mediastinum blind, whereas I did all of mine with EBIS. And so I don't necessarily know the utility of learning that without that ultrasound tool. Where navigational bronchoscopy you bring up the landscape is continuously changing. And not all of this technology is well studied or well studied against each other. And so I think it's helpful to, one, study this to find out, hey, is this new flashy technology actually helpful and worth the cost versus the older technology? And then also some providers in other locations, like I've talked to providers in Canada, for example, who don't have access to robotic bronchoscopy. And so they are learning in more of the older ways of biopsying lung nodules and things. And so I think that might be more location or provider specific, such as if you were an interventional pulmonary doctor, you may want to have greater breadth in the different procedures you can perform.
Yeah, it's one of the strengths of our kind of ability to have access to a lot of different techniques and otherwise. Because I remember one of my co-fellows was going off to practice somewhere, and he was facile with video laryngoscopy, but they only use a specific brand that is completely different. And we had access to at least something similar to that brand, and so he was able to get a couple of repetitions with that and some practice and supervised practice with that before he ended up starting practice. So I think that's really important.
Yeah. And I think it's really important too, what you said, Kaele, just to emphasize again, the importance of research and really understanding the value add. I am fortunate enough to be part of a generation, when I started learning central venous catheterization of the internal jugular vein, it was done just with palpation. There was no ultrasound, right? And so that's how I learned to place IJs. And then during my residency, ultrasound really became available to be utilized. And I would never go back, and I think now we have enough time to really see the advantages of the use of ultrasound. I'm not sure that every AI tool that comes down the pike will be as revolutionary. So I think it's important, as you said, to have things be studied and critiqued so that we know the technology that we're using is really of benefit for safety and for the patient. And then the other important piece of this is, again, it's necessary to have supervisors and faculty that are keeping up with the technology. And I don't know if this is unique to my own environment, but it seems that sometimes learners are adapting and to new technology at a faster pace than perhaps some of the supervising faculty. And so I do think this brings up questions about maintenance of certification, faculty, continuing medical education, making sure that the people supervising the thoracentesis of today are aware, and the chest tube of today are most up to speed with the technology and the resources available that our trainees are going to want to use.
Yeah, no, that makes a lot of sense. I think this has been a really enlightening and enriching discussion for me. I was wondering if either of you had any closing thoughts or any thoughts on what we can do as educators to continue to promote procedural excellence, whether it be as the proceduralist or the providers who are taking care of the patients before and after.
So some thoughts that I have would be, it is really important to have program directors and other faculty involved in education to have a common voice together and to be sharing experiences. And so I think we all learn best from each other, and we learn in community. And so I'm really grateful to people who've done good work ahead that I can learn from and be a voice to contribute to that. The other thing is to really recognize that your program experience, while there are some common things that all pulmonary and critical care trainees should be exposed to that are outlined very clearly in the ACGME and ABIM procedural competency documents, there are some unique aspects of your training. And so if you're at a place that has adequate navigational bronchoscopy exposure, your training program may have that as a procedure done by fellows, whereas if you're not, you may not be in that same way. And there doesn't have to be a completely uniform experience across programs. And so I think having the freedom as a program director and as a leadership team to really focus in on a curriculum that makes sense for you, that's going to give your fellows what they need, but then also take advantage of the unique aspects of your training environment. I think that ultimately in the end is what makes training great.
I would echo everything that Meredith just said. And just to add to that, sort of thinking back on a comment that was made earlier during our discussion, is that, this is not just about the trainee that's in front of us. It's about the patients and the patient care that we're providing, and having a good, supportive sort of progression in procedural training is both good for the trainee because they're going to feel more comfortable, confident, and supported. But it's also important for the patients who are ultimately undergoing these procedures. And so just wanting to bring that back together, that's something that I always emphasize when I'm talking about procedures to my trainees, is that this isn't just about you, although I'm focusing on you, but this is about the patient and the patient comfort and patient outcomes. And I think that is all I have to say.
Yeah, that's awesome. I think that's a great point to close on, that we're all here for the patients, and I think that patients, and at least I can speak for myself, can rest assured that there's dedicated and smart people like you, Kaele, and Meredith as well, who are thinking about this and making sure that the next generation providers are able to kind of take care of the patients before, after, and during procedures. But so I'd like to thank everybody for joining us for today's ATS Breathe Easy episode. Please subscribe and share this episode with your colleagues. I know this is something that sneaks up on me every year, so I'll just remind everybody that the ATS abstract submission season is here, deadline November 4th. Don't miss out, and we will see you next time.
Thank you so much for having us. This was really great.
Thanks, Eddie.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more ATS Breathe Easy podcasts on Transistor, YouTube, Apple Podcasts, and Spotify. Don't forget to like, comment, and subscribe so you never miss a show.